saw that. Wow.
Nice. Hey, good morning, everyone. How are you? Welcome to PerfWeb 95, coming to you from our MediWeb PerfWeb studios. I'm your host, Joe Basha, here with my esteemed co-host, Thomas DeSalvio. How's everything going? Everybody's having a good day today, I hope. All right, let's just jump right into it. Let me do the opening statements, kind of housekeeping notes. To contact us, contact at perfusioneducation.com. That reminds me, I need to get you your email address. I asked Vicki and she hadn't done it yet. Contact at perfusioneducation.com. So make sure that you reach out to us there if you have a question, a comment, you want to tell us how awesome we are, you want to suggest a topic, you want to be a presenter. We can always do that remotely. We have all the technology that anyone could possibly want. We have it here. There's no question about that. Okay, the next thing up is our call-in number. There you go. 832-239-5358. 832-239-5358. If you'd like to call in and be live on the air, we'd love to hear from you. When that phone rings, let me tell you what, we get really excited in the studio. It's really a big deal. So anybody who wants to call in, please do so. Down here, you see the scroll bar. That has everything about our social media and all that kind of stuff, and the phone number will stay up as well on that side right there. So that stays up during the entirety of the program, okay? And let's talk about our MediWeb app, our critical care application for perfusionists. We're in the podcast. There we go. You can get this on the App Store. You can get it on Google Play. It is a super, super cool, useful app. It's got perfusion quick calcs in it. It's got ECMO stuff in it. It's got conversions in it. It has an IV rate and dose calculator in it. Everything. Now we do sell. It's $2.99. If I sell 1 million of them, I can retire. So I think we're about 999,000 short right now, so everyone wants to get it. And I'll tell you something else, too. We're going to use this app during my lecture today.
All right.
So you're going to want this app because you're going to want to use it during the lecture to come up with your own numbers, all right? So please check that out. And next on the list is our podcast. You can find us on whatever your favorite podcast streaming platform is, and you can listen to us in the car on your way to work, stuck in traffic, or if you just want to go sit in the, I guess in your driveway and turn it on and just listen to us. But I guess you could do that at home if you wanted. You could probably just pull up YouTube and watch us there, or LinkedIn, or one of the other services. Okay, let's jump into this. So, Thomas, we've all heard a lot about Goal Directed Perfusion.
Absolutely.
And I believe goal-directed anything is better than aimless directed anything. But I'm somewhat confused as to what goal-directed perfusion really means. And the reason I say that is because when I search it and when I review the articles and so forth, there seems to be only one thing that's focused on. So is there only one goal in cardiac surgery, and what do you understand this to be?
We've had a lot of discussions about that with different people, and nobody has the same answer. And I think that's our biggest problem. And then, of course, when people do have the same answer, the parameters within that answer are they run the gauntlet. So that has been our biggest problem with trying to decide exactly what goal-directed perfusion means. Mm-hmm. And it means something different to everybody. Mm-hmm. So when you give your presentation, some people may agree with it or disagree with it, and try to say why they disagree with it and what their experiences have been, because everything that happens in perfusion that a perfusionist does is based on an experience. And so every device that's on your pump, somebody somewhere had a problem and they decided they needed that. And it's the same thing with goal-directed perfusion. We don't know what we're trying to accomplish here.
Yeah, we're trying to figure out, is it a goal or are there goals?
Yeah.
And what are those goals? What do they mean?
Are these goals, or are these just actual things that you should be doing on a regular basis anyway? They should be established guidelines. Are they goals or are they guidelines? What's that? That's one of our biggest issues.
I think so too. So I think this will be interesting. I think I enjoyed putting this together. I had a good time. So in the Journal of Extracorporeal Technology a couple of years ago, Sray and Rance and these folks came up with a quick reference tool for goal-directed perfusion in cardiac surgery. And I think this, I looked at this and I was like, this is a really interesting article. I need to pull this out and really read it. And in this article, they go through some things that we'll see several times during this lecture today. You need to know your arterial oxygen content, and that formula is up here at top, and then you need to know your DO2 and your BSA and all of this kind of thing. And if you are wanting to deliver a DO2I of 280, then you take that, you take the blood flow times 10 times the cardiac, the arterial oxygen content divided by the BSA, and on the bottom there you see basically that formula that will give you the blood flow you need to achieve what you want. Or you could just reverse that calculation and come up with what the DO2 would be for whatever blood flow you were going to have and hemoglobin level and PO2 and all that. So what they did, and I thought this was very interesting, was to simplify the formula, they made two assumptions. And the first was that the arterial blood will be saturated at 100%. And the second assumption that they made was the PO2 was going to be at least 200. I think those are all reasonable assumptions on cardiopulmonary bypass. And so with this simplified formula, they were able to create a quick reference chart that would show the minimum flow required to achieve what they say is a safe DO2I of 280 milliliters per minute per meter squared. And I want to focus a little bit on the word safe and then that number, but only requiring knowledge of the patient's BSA and hemoglobin level. And here is their table. Now, I think this is excellent work. I think it's great work what they did, right? So if I have a patient who has a BSA of 2 and I have a hemoglobin of 8, I'm going to need to flow 4.9 liters a minute in order to achieve a DO2 of 280. That's this chart. And I think it's a really cool chart. And it goes through BSA 1.5 to 3 and hemoglobin all the way down from 7 all the way up to 11. And I'll tell you what is very interesting about that, of course, is if you make a 1 gram change in your hemoglobin, you drop your flow from 4.9 so 500 cc's per minute reduction. 10 theoretically should be a liter, not quite 900. But interesting chart. I found it useful. I think it's really good work that they put together here. When you compare their method to what is normal that we see as cardiac index. So I know some hospitals, especially those that keep track of certain metrics, want to know if your index flow was below 1.8, possibly 1.6, possibly 2. Each institution may be different, right? And everyone is flowing to an index. That doesn't necessarily mean that you're actually delivering, based on this, a safe DO2I, right? If you were to use this article as the holy grail of safety, okay? And I think that's very important, and one of the reasons why I'm a little bit uncomfortable with that term that they used. But let's just take a patient that has the same patient 2, and we're going to come over here, and I want to flow at an index no less than 2.2, and that's what I can get. And there were a 2, so they're on this line. I need to flow 4.4. But if that patient's hemoglobin is 7, I really need to be flowing 5.6. Exactly. An enormous difference, and that is clearly because the lower your hemoglobin, the lower your arterial oxygen content is, the more flow you need to overcome the reduction in oxygen carrying capacity. It's very commonsensical in my view. So What is the purpose? We're going to take a test. And during this test, I need everybody to please be paying attention. And Thomas, I want you to answer the questions too. All right?
Okay.
So I'm going to use you as a guide. So just put 1, 2, 3, 4, 5, 6. I think there's 6 questions, and just put either yes or no. All right?
You want me to answer it, or just think of it in my mind?
Write them down.
Write them down. Okay. So nobody else can.
No, I want you to say it. No, you can say it. You can. Well, don't let everybody. No, just write it down. I don't want people to cheat. So I want you all to do this for real. Okay? The goal of perfusion, of cardiopulmonary bypass, is to create a normal physiologic environment. Is that the answer? No. Okay.
No.
Question 2. To deliver sufficient oxygen to the body to prevent anaerobic metabolism, meaning you need to have a DO2I of equal to or greater than 270 or 280, whichever, it's just to say 280 and take that as a typo. But 270, that's kind of the magic number that I've heard read about several times now. Anyway, okay, everybody have their answer? Is that the answer? We're not doing too well here. Maintain an arterial pressure between 50, that's mean arterial pressure. Make sure we're clear on this. Maintain a mean arterial pressure between 50 to 70. You got your answer?
I got my answer.
Is that the answer? Keep the urine output equal to or greater than 30 milliliters per kilogram per hour. Maybe that's the goal. That we know we're providing really good perfusion. Is that the answer? No. Keep the cerebral oximetry numbers greater than 50 or not less than 10% of baseline. Maybe it's 15% of baseline, whatever device you're using, or I don't know what device. Yeah, all of them have something different. But keep the cerebral oximetry numbers, and whatever that device says is the minimum thresholds you should have. Is that the answer? Didn't think so. How about if we use lactate levels to evaluate perfusion adequacy? That sounds like a good idea, because if you're not developing a lactic acidosis, well, if your lactate levels aren't going up, you're perfusing the tissue sufficiently. Isn't that what we believe? Yeah, is that the answer? No. Provide a physiologic pulse pressure. Now that's a good one, because we have pulsatile perfusion now. Is that the answer? Okay, the goat's tired. He needs to go eat some oats. So I want to go back.
You know what? That was not bad.
Yeah, that's exactly right. Okay, create a normal, I just want to go over these, okay? So y'all grade yourselves. To create a normal physiologic environment with the technological constraints of the cardiopulmonary bypass circuit, cannulas, all of that kind of thing is just fundamentally impossible to do. It's not possible. So take that off your table. It can't happen. Delivering sufficient oxygen to the body, in other words, keeping the DO2I at equal or greater than 270 or 280, though I believe that's a good idea, 270, 280, not even close to being enough. Unless you're cold. We'll talk about that a little bit going forward here. Maintain an arterial pressure between 50 and 70. Well, we're going to review what we learned back in either senior high school or your first year of college, whatever it is, taking basic anatomy and physiology, that is nowhere near physiologic. Impossible that is going to, unless you have a totally really healthy patient. Maybe it's a valve or something like that, but very, very, very unusual trauma, gunshot wound to the heart. That patient might have a mean pressure that low. Young person, maybe. Not our patients, not coronary patients that are getting bypass surgery. Keep the urine output at equal to or greater than 30 milliliters per kilogram per hour. Well, you can stimulate the kidneys and drive them to make urine. You can do that. You still have to have blood flow, that's true, but you can have compromised blood flow to the kidneys and still get them to produce urine, even in that condition. But you can also have well-perfused kidneys and have no urine output. You can lose autoregulation to your kidneys. For example, if they're used to seeing a really high mean arterial pressure, that's what they're used to, and all of a sudden it's really low, probably not going to work too well. Terrible surrogate for renal blood flow. Keep cerebral oximetry at greater than 50 or not less than 10% of baseline. Now, actually, I think cerebral oximetry is pretty good. I think it works pretty well. It's a useful tool. It's not an only tool because the brain, the head, is going to, especially with its autoregulatory properties, if you have sufficient flow and pressure, they can autoregulate, but it is going to take preferentially what it needs. So the brain is not, it's good to protect the brain to measure this, but it doesn't really give you a good idea of whether you're perfusing the gut well enough or the kidneys well enough or any other organ well enough. Use lactate levels to evaluate perfusion adequacy. Well, I mean, you could have a lactate of, let's say, 5, and I can dump in a couple of liters of fluid, and that lactate level is going to be less than 2. So is that really, it can be skewed so quickly by either concentration or dilution. So, and actually in critically ill, in critical care medicine, a lactate level that is dropping, or I'm sorry, a creatinine level that is dropping is actually a bad sign, because it means you're flooding this patient with fluid. No urine out there and uric. You know they're in renal failure, but you see the creatinine going down. That generally means you are over hydrating that patient.
That's a good word.
Provide a physiologic pulse pressure. I've done a program on this before. The pump cannot create a physiologic pulse pressure. It's not the pressures within the system are so extreme, and you're trying to go through a small cannula into an aorta that is 3 or 4 times actually bigger than the outlet of that cannula, and the tubing length and all of those things. It just is not a physiologic pulse.
Yeah.
The upstroke is too slow. There's a lot of things about it that just don't really work well. What are some of the bad things that happen during bypass? Well, we have hypotension. We have loss of autoregulation. We have anemia, which is decreased oxygen carrying capacity. We have hypoxia. Now, do we all understand the difference between hypoxia and hypoxemia? So hypoxemia is a decrease of oxygen in the blood. Hypoxia is a decrease of oxygen at the tissue level. So if we're hyperperfusing, you have capillary shunting, anything like that happens, you can have a PO2 saturation of 100%, not have any hypoxemia, be completely saturated, but be hypoxic, have hypoxia at the tissue level.
Right.
It's a perfusion deficit. Exactly. We have fluid shifts, which create all kinds of problems as we third space fluid out and decrease or increase the resistance of flow through the capillary system. That's where these shunts can occur. We have serious inflammatory responses that occur, and that occurs from the moment of going to sleep, sternotomy, skin incision, sternotomy. That's trauma, and there's big inflammatory processes that take place. We have a loss of meaningful pulsatility, whether you do it pulsatile perfusion or not. You have a loss of meaningful pulsatility. Does that really matter? It may not. I'm not really sure, but I know that long term, patients do adapt very well to that because of the continuous flow, total artificial hearts and VADs. So there is an adaptive mechanism. I don't believe you can adapt in a short period of time, an hour to 2 hour pump run, or I mean, you have to be on it for, I believe, months. Yes, yeah. I was going to say weeks, but then months I
That
think
sounds
makes
better,
more
yeah.
sense.
Yeah.
Whether we believe it or not, we pump air, GME. There's SCADs. Remember, David Stump was very big on the SCADs thing. You remember that?
I've never heard of it. What is it?
SCADs, I can't remember what the acronym stands for, but basically if you have microemboli in the blood, the lipids form a coating on them, and they're much more obstructive than we think because they can't just break apart.
Right.
Like a gas bubble
they're
can
gonna
get
be
forced
more,
through.
Stroke.
More obstructive to the microcirculation.
Right.
And then, of course, the shedding of the glycocalyx. We all know this happens. Now it does repair itself over time, but it is a common occurrence, especially in the aorta.
Can you see a change of color in urine from shedding?
Of the glycocalyx? No.
Okay.
No, it's just a subendothelial layer, but it certainly is important, you know, for maintaining the integrity of especially in the capillary system, the integrity of the capillary wall and cellular walls. You get white cells that migrate out, all kinds of things like that. It just really contributes to inflammation a lot. So what are the things we track? We track, of course, death during cardiac surgery, and these are just published data. It's 1.3 to 2.9% average. The range can be much higher than that. The MI rate is 2 to 15%, depending on the case. Again, it can be. There's situations where it's even higher than that. Acute kidney injury, 5% to 20%, depending on what publication you read, and actually some publications have it up 25, even 30%. And then stroke.
Whose fault is AKI? The perfusionist.
Of course.
Of course.
Of course. And then stroke rate is between 1 and 9%, with some cases being even higher than that.
So what about pump head?
Well, pump head, and that's, of course, a different, very good question. So pump head can be caused by a variety of factors. However, I believe that there's been enough convincing data that points to manipulation of the aorta, cross-clamping, partial occluding clamp, cannulation, cannula insertion, all of that kind of stuff, as being a greater contributor to the subtle strokes, pump head, you know, any change in mental status, being caused more by atheroma and by embolic material more so than the perfusion deficit from not flowing enough. Agreed? Disagree?
Maybe.
Maybe?
Maybe.
Tell me what you think.
So if we go back,
Yep.
let's start here. A normal physiological environment. So I attended a conference once, and we had one of the presenters did this excellent presentation using microscopic pictures of of hard shells, and the amount of angular sections of a hard shell was phenomenal. And the guy that owned the company that made these hard shells was so shocked by that because he thought he had this great product. It turns out that this product is actually quite damaging to the blood. And he actually got up there and he said, you know, we did not know this. And he said, we're going to go back to the drawing board and try and figure out somehow something we can do about this. I don't know if they ever got it done or not. I know that we have coatings now, and they're, you know, some of the companies, they all call them a different name. I know that I've seen the studies on them, and I've seen at conferences presentations which ones seem to be doing a little better than others. They all have their advantages and disadvantages, such as some of them have made with heparin, which if you have a patient that has hits, then you don't want that. but you can't have more than 2 circuits stocked all the time because that's kind of crazy. It's cost prohibitive. So that's kind of out of the question. And then the X coating, which is, I think, a great coating, except its major problem is that it's slippery. And when you put it onto a connector, you really need to put a zip tie on it.
You do. I've seen those connectors pop off.
Yep,
I have.
We've had that happen. And so one time it happened, and one of our really good perfusionists, he's been a perfusionist for many years, and he's the calmest guy, and he's just an amazing perfusionist. It popped off the cardiotomy during the middle of bypass, and the call goes out, and so everybody comes running in. By this point, he's already taken it, and he's already put it in there. He's clamped out the circuit. We had really good recirculation points, so he recirculated all of any problems out. And after the surgery, I happened to be in the perfusion office, and he comes in, and somebody was like, "So, hey, are you okay? Do you need to go to the bathroom or anything?" And he looks at him and he goes, "Nope, I already did that." But anyhow,
I know who it was.
Yeah. So that's about physiological environment. We do the best we can with what we've got, but it's impossible. The tubings cannot, even with all the new coatings, they cannot duplicate your body. And I know people are working really hard with DNA and with, they're trying to make cells, which is, crazy Scientology. I've seen a homemade heart actually start to beat. It's just unbelievable to me. Granted, it would never actually work in a real stressful patient need, but it actually moved. They actually were able to, because we know what the human body is made of. We can look at all the elements and we can say we know what it's made of, but we can't put it into a bowl and mix it up and make a heart. But they're trying. Mm-hmm. So that's interesting.
That is interesting.
The thing that we learned from DO2 eyes was that the problem is always hemoglobin and hematocrit. It's always anemia. And when you're held to restriction that you can't give blood, or you can't hemoconcentrate, or you can't put albumin in the pump. And these are rules that are imposed on perfusionists by anesthesia or by the surgeon, or maybe even by the hospital, because they say albumin costs too much, so we don't want you using it. And that happens. And I understand all that, because people have had different experiences, and we have a cost crunch, and we have reasons to go about that. But anemia is always the biggest problem here. And so then we're limited. We have to flow, a patient, like in the example, a patient with a BSA was at 2.2, and you need to be flowing 5.5. But your patient doesn't have the volume for you to be able to flow 5.5. Or if you flow 5.5, the surgeon can't see.
The heart's pulled up. The venous drainage is being compromised. Mm-hmm. Happens all the time.
Right. So I think it's an excellent tool, and I think the biggest thing that we learned from following DO2 was that we need to flow higher. The rules of flowing 1.8 to 2.4 just got thrown out the door. To be able to function in our society, in the way we do things, with our limitations that are put on us, you've got to flow as high as you can, 2.6, 2.8. And that, anybody looks at that, they say, oh, you're overflowing, you're going to blow the cannula out, you're going to cause a dissection. Mm-hmm. There's those problems with that. But it's anemia, and that's the biggest problem that I wanted to mention with this one. So maintaining an arterial pressure between 50 and 70. The real question here, I think, is what are we trying to take care of? Are we trying to take care of the body, or are we trying to take care of the brain? Because early on, the number 50, which I'm going to get to in a second, was an acceptable perfusion pressure. And for a lot of places, it's acceptable still. I think the people that want 70 and 75 are actually more correct.
Shumway was 30. Back in the old days, it was 30 degrees, 30 cc's per kilo per minute of flow, 30 mean arterial pressure. 30, 30, 30. That was his rule, 30, 30, 30.
No,
his patients did terrible, by the way.
I could imagine.
A lot of them died.
The closest that you're going to come is because you've lowered the metabolism by 50% by going to 30 degrees. So
really, it's 40%.
40%?
And I'll explain why.
49%?
Well, that's a quick rule of thumb. We're going to get into that. That's actually in my lecture.
About that? Good.
We're going to talk about that.
I think Joe has got an excellent idea to present on that. But the biggest thing is that when I talk to actual neurosurgeons and neurologists, every single one of them said that the patients should have a mean pressure of 100 or greater. So the question is, by the time the brain does its thing by making the pressures be higher because everything gets smaller and the brain's auto-regulating, maybe it is 100 in the brain, but it's actually 50 to 70 in the body, but I wouldn't trust that. So the reason we can't go to 100 pressure as perfusionists is because everybody's scared the candy is going to pop out. Mm-hmm. That's the number one thing. And then number two thing is dissection. We're worried that you've got too much pressure, you're going to dissect. So we sacrifice that extra 30 units and go say 70 or 75. And that's what I just want to mention about that. Urine output at 30, I've seen so many times, and you made some really great points there, that a creatinine going down is not necessarily a good thing. And a creatinine going up is usually a bad thing.
Yes, this is true.
But it going down is not necessarily a good thing. And after you have achieved a certain level of balance on perfusion, where you've given enough albumin, you've pulled the water out of the cellular level, the edema, let's call it edema.
The tissue, the interstitial space.
Yes, you've got that pretty well handled. You've got a really good level of red blood cells. Does your kidneys really need? There's nothing to make urine with.
Yeah. Maybe
that's the problem. So
I think it's pressure.
Pressure, that's the other thing.
I'm 100% convinced it's pressure.
So here's the big deal, that I don't know how people, this is how.
And flow.
We were taught.
Right, and flow. Not just pressure, right. But pressure and flow.
We were taught this, in perfusion school a long time ago, that the studies were done and it was decided that, based on these studies, that if you had a mean blood pressure of 50 or better, then the kidneys would make urine. And the assumption is that the only organ that you can see working with an actual physical, it creates something, is the kidneys. And so they said that, well, if a mean pressure of 50 is good enough, then we'll accept mean pressures of 50, because that's what makes the kidneys work. And I think they sacrificed all the other organs, and particularly the brain, because they weren't thinking about that ahead of time to say that maybe the brain needs more. And so 50 is, or I guess 30, wow, that's low.
It's low, very, 30,
Yeah.
30 pressure. It was 30 degrees, 30 mLs per kilogram per minute of blood flow, and pressure at 30.
I bet you he could see his vessels, though, whenever he did his sutures.
Yeah.
Okay, now I am big on cerebral oximetry. The reason I'm big on it is because of the oxyhemoglobin dissociation curve. And it clearly states that you want to have higher CO2s. If you study it at all, that's the final answer.
I just had an argument with an anesthesiologist last night on a case that I was doing, who insisted that my PCO2 of 46 needed to be corrected. And I say, why? Do you not like this patient's brain? And he said, well, I don't like pulmonary hypertension postoperatively either. I said, you've got to be kidding me. You think you're going to get pulmonary hypertension with a PCO2 of 46? I mean, seriously now.
Yep.
But ultimately, I entertained him, and I went up 0.01 on the sweep and got it all the way from 46 to 45.8.
And then he was almost happy. And then the other thing about that is, so I think my personal opinion is the standards for perfusion should be set at 48 to 52. And then if you have a dropping cerebral oximetry, you can go higher. And I've had my sweep at actually 60 before I finally got the cerebral oximetry to go up.
You mean your PCO2 at 60?
No. My PCO2 at 60, yeah. Before I finally got the brain to open up.
Yeah.
And when it opened up, it was amazing. I mean, because remember, the hit that you're going to take on the other side, because your CO2 is so high, it's very short term. And the body can take the hit. It's the brain that can't.
And actually, by shifting your oxyhemoglobin dissociation curve right, you increase the oxygenation at the tissue level, because it releases it easier with the decrease in pH. So I think that makes perfectly good sense. And then the other question is it and this is something that I've looked into, and I'm still a little bit confused about it. Somebody may have a better answer than me, but is it the PCO2 that is the cerebral vascular dilator, or is it hydrogen ion concentration that is the driver for it? I don't know.
They go together. So that's kind of the question of, I think since they go together, you're going to have a hard time figuring that one out.
Yes, I think so too.
But that's a good point. It could be that. And what I was going to say about that too.
Sorry.
Sorry. I don't remember. I think that's good enough. So the main thing is that, cerebral oximetry, but also pressure, blood pressure and flows. That it always comes back to the same things. We're underflowing. If you're flowing a cardiac index of 2.4, you're underflowing. And the reason you're underflowing is because your limitation of being able to get rid of anemia, get the hemoglobin up to 10, which is where we kind of probably need to be on bypass.
Oh, I agree with that. I completely agree with that.
Yeah, I think you brought up the perfect answer to that is dilution lowers lactate. And it's an artificial number that, unless you know that, you think you're doing something good and you're really not.
And you actually have to have blood flow. You have to have perfusion in order to have a rising lactate. So if you have a hyperperfused condition and it's insufficient to wash out the lactate that's actually building in that vascular bed, once that gets established, which could be later, and you'll all of a sudden see the lactate level go up, but yours was perfectly normal
the whole time.
So when did this problem actually occur? Was it really in the ICU? The nurses get blamed for it, so that's good for us.
Yes.
But
okay, physiological pulse pressure. We just talked about that. The question is, does pulsatile flow make a difference? And when you follow up with patients afterwards, when you've used pulsatile flow for a period of time and also used linear flow for a period of time, you probably have the best answer for this. I know that the answer that I've gotten from most perfusionists of why they use pulsatile flow is because they're doing, it's the closest thing to the best that they can do for the patient. And so it's kind of like saying, well, we want to have high flows, we want to have high blood pressure, we want to have a good hemoglobin, and we want to be as close to, since the heart is pulsatile and it's doing its thing, that we have to do pulsatile flow. And I think if it makes you feel good, do it. If that's what
I completely disagree. Completely disagree. The reason for that is our job is to do less harm than more harm.
So you think that it actually is doing harm by doing
I absolutely do. I have measured the pressures in the circuit, pre-oxygenator pressure spiking over 400, beyond the limits of my ability to measure, and then dropping suddenly down well below like 50. And I see that as long-term, short-term on a case, you can get away with almost anything. We're going to talk about that here in a little bit. But long-term, that's very, I think that's very dangerous.
The biggest
and I think it's very deleterious to the blood components, the cells of the blood.
Because it's being shot through this tiny cannula. And then what we can't measure on the other side is the pressure drop. And so the question is, it has this massive pressure buildup, gets shot through this little tiny hole, comes out on the other side, and there's this massive pressure drop. Did you really do anything at all?
I mean, I think all you have to do is just look at the pulse pressure that's being generated. It's beyond non-physiologic. You have a pulse pressure of maybe 10, and there's no real upstroke. It's just sort of a waveform, a sine wave going across. And so is that really, we're not built that way. No. So linear flow is non-physiologic to our native physiology. But all I'm doing is substituting something else equally non-physiologic for this, but at the same time creating a very hostile environment in a more hostile environment in an already hostile environment. Right. And so to me, when I measure it on the scales of risk to benefit, I see very little benefit and very, very high risk. That is my opinion about it, and I'm taking it with me to the grave.
I agree with you.
But
I can see that. Look, my question was, pulsatile flow, if you really look at pulsatile flow, it's the entire job of pulsatile flow in the human body is to bring blood to the coronary arteries. What do you think about that?
I think that makes sense because you have to be in diastole when because the heart contracts,
Right.
squeezes the coronaries.
Yep.
You get some, very little, but you do get some coronary perfusion, but it isn't until the heart relaxes, the muscle relaxes, the arteries get opened up, the valve gets closed, and passive drainage from the surplus energy, because you have surplus
Right, surplus
hemodynamic energy coming back down.
Backwards flow.
Right.
So I was thinking about that. I thought that was kind of humorous. A couple of weeks ago, we did our last talk, and I went home and I was writing notes on it. And I said, wouldn't that be funny if the entire purpose of the heartbeat, the diastole portion, is just to feed the coronary arteries?
I don't think that's a bad thought. There's a part of that I think makes a lot of sense. We're going to look into that further. I like this.
What's that? Bad things that happen on bypass.
Yes.
I think you pretty well covered all those things.
I think so. Okay, so let's jump into stuff that I have some real interest in. All right, everybody knows the formula, CaO2, arterial oxygen content, times the cardiac output, divided by the BSA, gives you the DO2I, okay? Normal resting adult DO2I is 500 to 600 milliliters per minute, okay? Remember, we have a magic number of 280. Don't forget that, okay? Examples. 167 centimeter, 71 kilo female with a BSA of 1.8 and a hemoglobin of 13 with a cardiac output of 5.2 and a PO2 of 97 has a DO2I of 509 milliliters per minute per meter squared. A male, 180 centimeters, 113 kilos, 2.3 BSA, hemoglobin of 14.7, has a cardiac output of probably 7, maybe a little more, but if they're just laying there resting, that's probably where it's at. And a PO2 of 113 has a DO2I of 613. Now, these are very common patient sizes. We get these people all the time, right? Open heart patients are anesthetized, paralyzed, and I have hypothermic in yellow for a reason. So we need to sort of separate these two things out. Under general anesthesia, when you take a patient who is at rest and they have a basal metabolic rate of X, putting that patient to sleep and paralyzing them reduces that by somewhere between 10 to 20%. So we're just going to say 15% for the sake of our argument today, in the middle, all right? Now, hypothermia, and that's very a strong contributor. They say that a 7-degree drop in temperature results in a 49% decrease in metabolic rate, right? Mm-hmm. Okay.
Right.
But if you take a metabolic rate of X, and we're going to make X 100, and you reduce it by 7%, and then you reduce that number by 7%, and you go on down the line, you're actually only reducing it by 40% by the time you get to this 7-degree mark. You can't say 7 times 7 because the number is getting smaller and smaller. And so that's the it's very easy to remember 7 degrees, 49%. I think we learned that in perfusion school and basic classes that we take.
We call it 50%.
It's not. In reality, it's 40%. It's actually a lot less of a reduction than we believe with our anecdote. Okay? And you can do the math on that yourselves. So let's go back to that female here, the first female, 167, 71 kilos, 1.8 BSA, all that stuff's the same. 509 is their basal metabolic rate, their DO2I, and we reduce it just by anesthesia alone, and we get to 432. That is her required DO2I, or what she's actually getting, which is probably surplus, right? We agree with that. But without, if you did not cool this lady, she was at 37 degrees, or you just drifted 35, 36, and then came back up, that 280 suddenly is nowhere near what her actual basal O2 delivery index is. You have to cool her to 30 degrees and knock off an additional 40% to get her down to 259, in which case that magic number of 270 or 280 would be enough. It's pretty close, right? Okay. But you have to start off warm, then you have to warm the patient back up again. We spend very little time in the hypothermic zone because we're always moving the temperature 1 degree or another. Now let's look at this male. He has a basal DO2I of 521, and that's after anesthesia. You have to cool him to 30 degrees, which is still only going to get you to 312. Is the magic number of 270 or 280 enough for this patient? From what their basal rate would be. It's somewhat close, but at 35 degrees, it's nowhere near close.
Right.
This, I believe, it's a good idea, and I'm going to show you some data that I think is very important. I do think it's important. I think what we're doing is important. The concept's important, but it's not enough. And we're going to, and a lot of it has to do with hemoglobin, which you just got through talking about, and I think we're going to agree on this. But you cannot translate any of these numbers to any individual organ. This is in totality.
Right.
Organs that are essential are going to take what they need. The skin, the gut are going to be compromised. They're going to get compromised first. So your 270 really isn't 270 to the whole body, or 280. It's not to the whole body, right? And I think that's another important factor, is that we're dealing with a dynamic environment. We have a dynamic tool dealing with a dynamic environment, doing dynamic things, all interacting and confounding each other at the same time. And hopefully somewhere along the way, augmenting each other, but a lot of times compromising each other. So this article here, good article out of the Journal of Cardiovascular Surgery. They basically had two arms, a DO2 arm, DO2 controlled, and a conventional. You can see here that using DO2I of 280 decreased your AKI rate. Again, these are all talking about AKI. Everyone's talking about AKI. And I do think that's really important because it's something we know is way too high. So I appreciate so much a lot of these researchers who have spent so much time learning and trying to reduce the acute kidney injury in cardiac surgery, because it's been a huge problem for years and years. But in this here, they kept their DO2 at greater than 300.
Okay.
Big difference.
Yeah.
Big difference.
I don't know how they did that, though.
Well,
they had to have flowed crazy high, and they had to have given lots of blood.
Very liberal transfusion strategy. That's how they did it. They didn't let the hemoglobin go to 6 or 7. Goal Directed Perfusion, again, to reduce acute kidney injury. And actually, this is the authors, Ranucci and Johnson, are the authors who really began this whole journey that we're talking about. I love that word, journey. Everybody's on a journey. I'm on a journey today, too. I'm on a journey to get an ECMO decannulated this afternoon. Yes. That's what I'm on a journey for, okay? But anyway, with that said, this is out of also the same journal, Journal of Thoracic and Cardiovascular Surgery in 2018. But Their objective is to determine whether a goal-directed perfusion strategy aimed at maintaining oxygen delivery at equal to or greater than 280 milliliters per minute reduces the incidence of acute kidney injury. Again, when you hear people talk about goal-directed perfusion, they're specifically talking about one goal, and that is a DO2I of 280 or greater, or 270 or greater, whichever again it is, and acute kidney injury. That's it. Reducing acute kidney injury by doing this. One goal. But cardiac surgery has many goals. We're going to kind of get through that. It was a multi-center randomized trial, which I thought was very interesting. 350 patients in 9 institutions. And we'll just kind of get to the results of this, and it's pretty clear. Here's goal-directed perfusion in red, control in blue. This is your AKI stage 1, stage 2, and any AKI. And you can see that stage 1 and any AKI much improved. There is a little bit of a skewing here, which I found odd, but I think that both are very low. So I don't know that really was statistically significant in their discussion. But in their conclusion, a GDP strategy is effective in reducing acute kidney injury, stage 1, AKI. Further studies are needed, of course, that may reduce more severe levels of renal injury, meaning AKIN, which is the acute kidney injury network, stage 2 or 3. But I do think that the work was really important. Here's more about their outcomes, and they're using any creatinine increase. Again, that can be really skewed. But if you look at AKI stage 1 in the GDP arm, 11.5% versus 22.4. Stage 2 was 3.8 patients. I think that's in number of patients, not percentage. And 2.4, so a little bit worse here in this arm. Here in the of any kind, you have 53 versus 61.2, so improved there. And that is overall population. For CPB times of 1 to 3 hours, you see better outcome here, a worse outcome here, better outcome here, and in any creatinine increase, better outcome here. But still quite high. Still quite high, What are the variables that are controlled by us? Well, we control the flow rate. Mm-hmm. We control the SVR and the mean arterial pressure with pressors and flow. What is the best treatment for hypotension?
Blood flow.
Blood flow, not pressors.
Not pressors,
but
yes.
You do want to have an SVR that is somewhat in the normal range. And I challenge my colleagues that may be watching this show. How often do you try to consider what the SVR is? Yeah. And how often is your SVR well below 800 or way above 1200, which 800 to 1200 is considered your normal range.
So what's bad about it being above 1200?
Well, you're vasoconstricted. It's like a patient who's on rocket fuel in the ICU and their fingers are turning purple.
Exactly. You have shunting.
You're
going around all the organs.
Yes, right.
So it's the same thing as having a below 800 SVR.
Right.
So
you're not getting losing autoregulation. Right. Exactly. Both are bad. As far as they both create a perfusion deficit just for different reasons.
Right.
Ultrafiltration, we can do that. Transfusions, we do that. Temperature control, we do that. Pulsatile versus non-pulsatile, we do that. Just get rid of that. Okay?
Would you add in there PO2?
Sure, PO2, absolutely. Every one of my cases for the short duration that I do them is on 100%. I never turn my FiO2 on my pump circuit down below that, unless I'm doing circ arrest and I'm reestablishing. If I'm reestablishing off circ arrest, well then I'm trying to protect the brain from having hyperoxemia and oxygen radical development and all that stuff.
Yeah. So I think that's important because everybody's been taught that when you have a PO2 of 400 or greater, that you are potentially introducing micro air emboli into the plasma versus being on the hemoglobin. And I think that the more that we started controlling DO2s, when we started running, we were forced to run our saturations at 400. I mean, our PO2s at 400. And because the big problem is they don't want you to give blood. They won't let your hemoglobin go to the numbers where it needs to be. So you compensate, you go, you just leave your oxygenator at 100%, and even though these oxygenators are pulling out a PO2 of 480 or 500 sometimes, you leave it at 100%, and you flow as hard as you can. And that's how those are the two things that are
achieve
it,
again, the arbitrary goal. I'm going to talk about the arbitrary. I'm going to talk about the goals here. We're getting there. We're getting to an answer to the question, and hopefully we won't get a goat.
Right.
Okay. What are the
or a negative review on it?
A negative review. Yeah. Did I get any thumbs downs yet? Let me see. No, we have 12 thumbs up. That's good. Give us some thumbs up. Come on.
Before we talk about bad things, we should say, hey, give us a like and a subscribe. It's great for spreading the news, the word about us. And if you think that what we do is beneficial, our conversations, because we have conversations, we have presentations, but we have conversations. And you're welcome to call in and contribute. You're welcome to.
I would love to hear
comments.
that phone ring.
Yeah.
I would love to hear that phone ring.
I've been to 3 of these now.
Have you ever seen the excitement that I get, and how excited I get when the phone rings?
Well, I hear about you talking about it, so I see how excited you get. So
okay,
that's
somebody call in. Help me out here.
I want to hear that phone ring.
So, what are the evil things about cardiopulmonary bypass? I love when you do our little notifications like that. I never remember to do it, and they get mad at me back there. Evil things: hemodilution, excessive, GME, massive inflammatory response syndrome that occurs, hypotension, hypoperfusion, loss of physiologic pulse, need for transfusions, microvascular perfusion derangements, and I added this. It's not really an evil thing about CPB if you do something about it, but lack of colon-oncotic pressure management. I think it's very underappreciated by a lot of us. Everyone I do cases. Everybody in every prime gets 50 grams of albumin. More if they need it. If they come in malnourished, they've been in the hospital a while, their albumin is 2.1.
There you go.
Hypoalbuminemia is an independent predictor of mortality following cardiac surgery. So, let's think about that, right? There's so many things to think about.
Right, and people accept a 3.3 as a normal albumin.
It's not.
And I keep telling you.
4 or above.
You got to have 4.5.
And does anybody here know what the toxic threshold of albumin is?
0.
There is none.
Yeah,
There's none. You cannot overdose albumin.
So I was thinking about that. The biggest problem, the only way to reduce anemia in bypass is to have as low a prime as you can have. And what I think is funny is people count prime, they say it's crystalloid. They call it your plasmolite or your whatever you're using, LR, or whatever you're using, and they don't count the drugs. They say drugs don't count. And I always think that's funny because that counts. It's a diluter.
Right.
It's a drug, but it's still diluting you out. So when you give 50 grams of albumin and you're giving, 200 cc's?
Mm-hmm.
So that's an extra 100 cc's that's not actually plasmolite, but that extra 100 cc's of something that is colloidal that is going to keep the blood in the arteries and veins and pull water and edema that may already be in the patient because they probably have been in heart failure for a while.
Right.
They probably have stuff that...
And anesthesia has gotten a hold of them.
Yeah. That's another thing.
And their only treatment for hypotension, hypertension, and normotension is to just give more volume.
More volume.
And each gram of albumin will pull back 18 cc's from the interstitial space.
That is excellent. 1 gram.
1 gram of albumin equals 18 cc's of fluid coming back from the interstitial space.
Yeah.
So if you give 100 grams of albumin, if the volume is there, there's an assumption that the patient has third spaced. If you give 100 grams, you pull back 1.8 liters.
So what's amazing about that is, so if you gave 25 grams, you would pull out, how much would you pull out?
Well, 10 times 180 is it'd be 180, 360, and half of 180 is 90, 540.
450.
450.
Right, 450.
540, I've just composed the numbers.
You could potentially increase the volume in your reservoir by 450 cc's.
Yes, and it will, because everyone who goes under general anesthesia that goes through that initial process of induction and then the prepping and the draping and all of that kind of stuff will have a bare minimum of, no doubt, have 450. I would say they probably have 2 liters of excess fluid in their interstitial space.
So let's do this then.
Minimum.
Yeah, and this is an excellent time for you as a perfusionist to think, I've got an extra 450 cc's. And instead of being happy that you've got extra volume in your reservoir, take a hemoconcentrator and pull that 450 out. Now what have you done?
Well, you actually, when you take that out, you increase your COP even more. So you have what's referred to as the PRR, which is your plasma refill rate. And at the capillary level, you have fluid that leaves the vascular system into the tissue, comes through. Some of that ends up in the lymphatic system. Some of that gets reabsorbed, depending on what the differential in pressure is, your oncotic pressure forces are, back into the vasculature and then back out. As you increase, as you hemoconcentrate, because people have asked me, how are you still hemoconcentrating volume when you only had a liter in your tank, but now you have 1,200 and you gave nothing?
Yes, exactly.
And you've taken 500 out, you've taken 600 out, and that's because you're increasing the plasma refill rate as you concentrate the blood, both the hemoglobin, of course, the hematocrit, and which is going to contribute significantly, and your albumin.
Right.
That's your largest, but albumin is your largest contributor to oncotic pressure. It's like 60%.
Oh, I can't remember what I was going to say now.
You'll think of it.
Yeah, I'll think of it.
Okay, so what are the evil things associated with open heart surgery, not the perfusion part of it? Well, induction of anesthesia, skin incision, sternotomy, all of those things are very traumatic and evil. Manipulation of the aorta, cross-clamping, partial occluding clamp, probably the more significant contributor to neurologic events that occur during open heart surgery are caused in that area. Bleeding and what sucker they use. You're bleeding, they can't see, they want high suction, they stick the cell saver over the hole, and they suck out a liter of blood to the cell saver. And you're sitting there struggling, trying to have a DO2I of 280. Well, that isn't going to happen on that day. So you're in trouble. Or worse, they take the pump sucker and they shove it, and I keep an eye on them, but they shove it into the left chest from where it was open because they took the mammary down, and it's nothing but a bunch of diluted irrigation, cold, diluted, full of inflammatory mediators. Your crit bottoms out, your DO2I bottoms out, your blood pressure bottoms out. So there's this management issue that we don't do a very good job with, but I really try really hard. Irrigation that ends up in the pump. I get in arguments with these people all the time. But some of them are really well trained now. I've trained them, and they're really good about it. They entertain me. All right, I'll entertain you, and they put it over there. But I think in their mind, they really know I'm right. They know I'm right, or they wouldn't do it. Air. There's lots of air. You can't do a heart surgery and not have air. Not necessarily coming from us. There's air in the intracavitary air. Air gets everywhere. There's just air. The worst.
So what you're saying? You remember you're saying that you
Oh, yes. No bubbles, no troubles, but what's a little air among friends?
What's a little air among friends?
That's right. Slow surgeons, long pump runs. And look here, Journal of Thoracic and Vascular Anesthesia. Cardiopulmonary bypass duration is an independent predictor of morbidity and mortality after cardiac surgery, done in 2008.
You know what's funny? The only people who will disagree with this are slow surgeons.
Right, exactly. So slow surgeons, we can't do a whole lot about them except maybe just refuse to do their cases. Slow weaning, low cardiac output syndrome, need for rocket fuel. This is just when you're using rocket, when you've got 18, 20 of norepi going, and you've got, vaso going, and all of this stuff going.
What's your cure for that?
Mechanical circulatory support.
Well, increased blood flow.
Yes. Don't try to stay off bypass. Go back on bypass. You need mechanical circulatory support. Don't wait until you're at those levels to make that decision. If you get to if 10 of norepi and I don't know what 16 of vaso, something like that, whatever the numbers are, I can't remember the dosage, but moderate doses, and that's not enough. You're not going to have, you're not going to make it. And you're still on pump, you're kind of weaning off, and you need that to get off. Just go back on, put a balloon pump in. Don't get all of that, those receptors activated with all of these drugs, these vasoactive drugs and inotropes and all that stuff, because it's just whipping them. It's not good for them. So just go back on, put a balloon pump in, try again with low doses of those things. If that's still not going to be enough, you're going to have to do something else surgically or put them on ECMO. That's what you got to do. Okay, so that's that. Again, their conclusion, prolonged CPB duration independently predicts postoperative morbidity and mortality after cardiac surgery. That includes acute kidney injury. This I thought was great. I loved this one. Journal of Thoracic and Cardiovascular Surgery. Here's your authors here. And this is very interesting. Percent of cardiac surgery associated AKI. Very good. I'm going to go to the magic number of 280. It's 18.6%. 240, 24.7. But look at how linearly it decreases the higher you get. The more blood, the more oxygen delivery, the better off you are. And this, I think this study really illustrated that well. So, how does anyone survive bypass? And I believe it is the ultimate in dichotomies. One, it is really incredibly hard to kill people.
Have I ever told you my saying that I made up?
No.
As hard as it is to kill someone, it's very easy.
Exactly.
As easy as it is to kill someone, it's very hard.
It's a dichotomy. It truly is. And there's examples of this.
I just a good time for me to tell you. I've seen everything go wrong, from just a really sick patient to equipment malfunctions and a sick patient to just plain malpractice. And the patient will wake up the next day fine. And you sit there and you're just like, what happened?
Well, I gave a talk one time. I'm going to give the talk again one day because I think I have something to add to it. But the title of my talk was The 4 Times I Tried to Kill a Patient, but they lived anyway.
Yeah. I can't wait to hear that talk.
I've done
the
it.
other thing about it is, the other side of the equation is that I have seen, a 48-year-old healthy person, 2-vessel cab, none of the parameters are off. Everything, you've had a great pump run, everything is perfect, and they die.
Yeah.
And you sit there and go, I don't know about what other people do, but I always reevaluate my cases. I always go back and look at them. I'm constantly reevaluating myself and what could I have done better? Where did I make mistakes at? And I give myself an F if I make one mistake, which generally means it's not often that I have a perfect case, but I'm trying. But when I look back at some of these cases and I try to figure out what could have possibly contributed to this, on my end, everything is in parameters. They just died.
That's weird.
Yeah.
So this is me talking. there exists a definitive line, uber thin, nearly invisible, and unpredictable as to its location, that once crossed, there is no return. We don't know where that is, though.
No.
And examples of this are looking at the Tunnel to Towers ads. And I see those guys that got blown up. Every single one of their limbs just
Ejected.
separated from their bodies. And they have somehow, they're otherwise intact. They're alive. You know, they're enjoying their life. And you think about, how can you get blown up to the point that 4 of your limbs get blown off of you? Because there has to be trauma elsewhere too, that you survived that. I mean, look at, you know, that guy that's on Fox News, Joey Jones, you know, bomb technician expert in the Marine Corps, got blown up, both of his legs amputated immediately, and he's gone on to have a perfectly normal, otherwise normal life. I mean, I think that's just remarkable. But what about patients getting elephant trunk surgery?
Ouch.
I mean, you talk about a traumatic case, an event. I mean, it's just, I've never actually watched one live. I've only seen videos of them, and I just don't want to do those cases because they scare me. But people survive them. Circ arrest cases, just a basic circ arrest case. Think what we're going to do to you. We're going to take a person, you're going to take you, we're going to put you on artificial circulation and oxygenation, the heart-lung machine, cardiopulmonary bypass circuit, whatever we want to call it. We're going to cool you down to your body temperature is somewhere between 12 and 16, 18 degrees maybe, usually below 18. Some people go to 12. Mayo Clinic goes to 12 degrees. So some places go that cold. Then we're going to stop all the blood flow to your entire body, and we're either going to flow retrograde up your superior vena cava and flow backwards through your brain to give you some supplemental protection, or we're going to flow antegrade through the axillary and clamp the innominate and let it go up one side, or they're going to put catheters in your carotid arteries, and they're going to flow directly up your brain. We're going to do something. And those people wake up and do great. And it's just amazing.
To me, what I think is funny is I've done a lot of those kind of cases, major cases, and I've watched other people do them, and you'll see them leave their FiO2 at like 60% and their sweep at 2.5 or 3. And
at that temperature, that doesn't make sense.
Well, exactly, because you're flowing up to the brain.
Solubility of CO2 is, I mean, at that lowest
CO2.
CO2.
Your CO2 down to
nothing.
10, 5.
Yeah.
And you're supposed to be, it's supposed to be good for the brain. You have to remember to turn those things down. Mm-hmm. I have to have my
sometimes
sweep
it's
at
better.
0.5.
Sometimes it's, sometimes it's 0.1.
Yeah.
You can be
As
very,
low as I
very
get
low
it.
and get your FiO2 down to 21%.
Yep.
Again, especially when you start warming and reestablishing normal flow. And I think you really need to look at Matt Warhoover and the work done at Vanderbilt to fully appreciate this, because they're so good at they do so much DCD where they take patients, they die, there's a standoff period, they're dead
Mm-hmm.
for like 15 minutes, 30 minutes, sometimes even an hour, if I remember correctly. And then they quickly do a sternotomy, shove cannulas in, no purse strings or anything, and go on bypass and reanimate at least the heart. Now, they clamp the arch vessels to make sure the brain never does wake up. But,
Right.
I mean, the brain's not going to wake up. They're dead, okay? And yet that heart becomes very usable.
Viable, yeah.
And so that's amazing at what they can do. So, like I said, it's really hard to kill someone, but it's really easy at the same time. It's just such a strange phenomenon. I really want to go over this. This is very important as far as I'm concerned. I'm not going to go into all these details. All I'm going to look at here, and you need your calculators for this. If you don't already have the perfusion and critical care app, please get it, open it up. We're going to use it. So here we have the common method to estimate the mean arterial pressure is the following formula. Mean arterial pressure equals diastolic pressure plus 1/3 of the systolic pressure minus the diastolic pressure. Simplest formula you can get. Now there's another easy one. It's 2D plus S divided by 3, if I remember correctly. But this is one that's published in a physiology magazine. Okay, here is a patient. Patient's blood pressure is 140/87. So I'm going to come up here. I'm going to open my app. And we're going to go to, we can go to perfusion. So you want to know the DO2I. So look here, you just type in DO2I. You don't have to do all the back formulas. You can put the hemoglobin in as 10. The SaO2 is 100. The PaO2 is 200. The cardiac output is 5 liters. The patient's BSA is 2.2. Am I flowing enough? Make it 5.5. Am I flowing enough? Patient's BSA is 2.2. 355 is my DO2I. Let's change this to 7.3. Calculate. Am I flowing enough?
Barely.
I'm not. It's red.
Oh, okay.
It's got to be over 280.
280, okay.
You didn't hit the magic number. You would have to now increase your flow. Say 5.8 does. 278.
Didn't make it.
Didn't make it to 280.
Close.
Okay, let's say
You want to be precise.
5.9. 282. So I don't know what the because normal is not based on that flow. Normal is 550 to 650.
Okay.
That's why. Anyway, go to this app. It's very important. I want you to do that, okay? All right. Let's go back here. All right, so 140/87. Let's use our formula. Take 140 minus 87, and what do you get? 140 minus 87 equals, what do you get? Here, use a calculator. I'm not very good at math. Here.
60 is going to be 53.
53. Okay, 53. And so we need the diastolic pressure plus 1/3. So 53 divided by 3 equals, here, just use a calculator. Faster. 53 divided by 3, because you need 1/3. 17.66. Okay. And then plus the diastolic pressure, 87. 104. 104.6. Now just say 104. This patient is walking around with a mean arterial pressure sitting in their chair of 104. Right. And we're going to have their pressure at 50 or 60 and think we're okay. Okay, let's do 118/75. Let's say the patient's not a hypertensive patient, more of a normotensive patient. That's pretty doggone good, right? We need to take 118 minus 75 equals, divide that by 3 equals, plus 75 equals, the mean arterial pressure of this patient that they are used to is 89. That is what they are used to. Their physiology is adapted to that. Now, if you had a patient in the critical care unit and their blood pressure, not on mechanical circulatory support, was 83/50, they're a post-op heart patient, are you going to be very happy?
Nope.
No, you're not? Okay. So let's see. Let's see why. 83 minus 50 equals 33 divided by 3 equals plus 50 equals, that's a mean pressure of 61. That's about where we are on bypass many, 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 many times.
Yep.
But yet, look at what that actually means. So if your kidneys are used to an 89, if your kidneys are used to a 104, it is not just about the DO2I. If you don't have the driving pressure to those kidneys, they are not going to work. It needs that pressure for there to be appropriate flow through the circuit.
Through the kidneys.
Through the kidneys.
Right.
156 over 91, we have a lot of patients like that. 156 minus 91 equals, hey, we need to add this to our app, Magic. We need to create this for that's our next update. Our next update will be mean arterial pressure. Right. Over 91 divided by 3 plus 91 equals 100. And this patient is used to 112 millimeters of mercury. On CPB, commonly 50 to 70, maybe 80, but more commonly 50 to 70. Knowing what the normal BP, and this is my words, BP of the patient has been, what it normally is, not what it is when you come in the OR, anesthetized, dilated with Presidex or whatever they're going to use, all that stuff. Knowing the patient's normal BP when they're at home is critical to understanding the patient's adapted physiology, vis-a-vis adapted autoregulatory systems, specifically for the brain and the kidneys. We run mean arterial pressures way too low.
Exactly.
So, what is the answer? What are the goals of CPB? Again, Joe's words,
Right.
not published.
We have mean arterial pressure under hemodynamics.
We do? Let me go to it. Facilitate an operation where the native cardiopulmonary bypass system will be omitted or compromised too much to allow the operation to be done safely. So we're there to facilitate an operation to be done where the native circulation has to be removed from the circuit, or it would be too compromised to do it. And to minimize the deleterious effects of artificial circulation and oxygenation, because everything about artificial circulation and oxygenation is deleterious.
Right.
Nothing about it is good. We can mitigate, minimize it as best we can, but we can never say we make the patient's physiology better. We control it from becoming worse and deteriorating further. That's all we can do. Agree, disagree?
Agreed.
Okay, now let me go back to the app, because I was having like a minor stroke. I meant to go there
How could
anyway.
that not be here? I
Hemodynamics.
know we would have done that.
Mean arterial pressure. Look at this. Go buy the app, please. If you're not looking, not listening, go buy the app. Look, you can't even see me. I'm covered up.
At a minimum,
I'm
at a minimum, you'll have so much fun because you can in your mind practice and think where you think it's going to be, what the numbers are going to be.
Yes.
And then you put the numbers into the app and you see if your numbers correlate with the app's numbers, and then you can look and see what the actual numbers are. I have a blast with the app. I love it.
I think it's a great app. I really do. 126.
You've done a great job on this app.
Diastolic pressure, 83. So a little high, but not bad. You know, but this is what they've been in the hospital when they go and check it. You can always have a little white coat hypertension, you know. Calculate, look at that, 97.3. It does all the math for you. Just put the systolic pressure, diastolic pressure, and this gives you your mean arterial pressure exactly. So real quickly, I'll just kind of go through this if you don't mind. When you first open the app, what you're going to see is this symbol right here, yeah. And I'm going to push it. You saw it click, and then it pops up MediWeb. It gives a little advertisement for what our next program will be, but you can skip it just by hitting the X if you want. You have perfusion apps. You can go to perfusion quick calcs. You can say you've got a female that's 65. It's based on weight. It's based on volume per weight. So we're going to say this patient is 57-year-old female, has a pre-op crit of 32, 165 centimeters. We'll say she has a high frailty score and she's somewhat undernourished or whatever. We'll give her
65 or 60?
Yeah, 60 I think sounds good. 60 kilos. Your pump prime, let's say you're gonna wrap. Okay, with wrapping, unless you wrap the entire circuit, and if your circuit, depending on the size of your circuit, you may not be able to because you won't have volume.
You can't wrap that.
We're gonna say the pump prime is 700. We're gonna be pretty aggressive.
That's fair.
Anesthesia, we're going to say they're really restrictive, and they only gave, I'd say, a liter, but what do you think? Let's say 750.
Yeah, 750, I think that.
That they were really careful. Pre-pump urine was scant, 100 cc's. You're going to give 300 calculated heparin dose. Your BSA, your BMI, your estimated blood volume, 4 liters, your red cell volume, your heparin dose, your estimated crit on bypass is going to be 23.77 if all things remain equal. They probably won't, but it gives you that. Then it also gives you all of your calculated flows. So you can take this patient that has a BSA of, what did I say the BSA was? 1.66. You can come back out of here. 1.66 DO2I. Hemoglobin, I said was, what did I say? The hemoglobin crit was 31. So it's going to be 10.2.
Okay, yeah.
SaO2, we're going to assume 100%. We're going to assume greater than 200. Cardiac output, you're going to flow on that patient at what would be 2.2?
3.2 or something like that.
3.2 would be your flow.
What was your BSA again?
BSA was 1.66.
1.6.
So 2 would
Probably
be,
gonna be
so let's say
3.3.
3.5.
Okay, 3.5.
You're going to flow 3.5. BSA was 1.66. Calculate.
Yeah.
And in this particular patient, if your crit was 10, but what was the hemoglobin, the diluted hemoglobin?
23, so what is that?
That's 7.
7.8, 7.5?
7.5. 7.5. Correct that. Calculate. 228. That's where you're at on your DO2I on this patient.
Too low.
And are you really going to have enough volume to even flow? This is going to be a very challenging case.
And you can't hemoconcentrate because the hemoconcentrator takes up all of the volume in the hemoconcentrator.
Right, exactly.
Joe, we have a question.
Yes.
I will display one by one because I think it's
Okay, go ahead.
that's the first question.
But do you want to have a patient after aortic repair with a MAP of 112?
And the second question is,
Also, the MAP in the aortic root is even higher than that. Those are very good points. But is 50 adequate? Okay, so we're talking two different languages here, right? From a surgeon's perspective, and ours too, because the last thing we want to see is your aortic repair explode. That usually means we're not going to get out of there because we're perfusionists. Out by noon with no balloon. That's our mantra, right? So we don't want there to be any problems. So yes, I agree with you 100%. I don't want the MAP. No one should want the MAP at 112 to come off bypass. You have a cross clamp on, we're on bypass, the patient is used to a mean of 112. Should we have a mean of 50 on bypass as you're doing the repair where we're taking all that time up and you have a non-physiologic environment, again, not an adapted laminar flow, it's acute. So you're taking pulsatility away for laminar flow, and there's no time for the patient to adapt. So having a pressure of 50 when you shouldn't be having any trouble at all doesn't make any sense. Now, coming off bypass, having a systolic pressure of 100 and a diastolic pressure of 60, that's a 40 millimeter pulse pressure, still gives you a mean pressure of, let me see, hemodynamics, that's where it was, mean arterial pressure, 100 over 60, that's a pulse pressure of 40. That's still a MAP of 73. Higher than what we frequently see on bypass. You want it at 50. I'm doing an aortic procedure. I want the pressure at 50. Well, why? You got a clamp on the aorta. This shouldn't be a problem if your clamp is
Right.
stable, right? That's my view on that. But you bring up a very good point. Okay.
So I think that
And
most
fair.
Yeah. Having done a lot of those type of cases, when you come off bypass, most surgeons, they want their pressures to be less than 100, the systolic pressure.
Yes.
And I think it's prudent because what we're looking to see, how well is the graft sewn on? Do we have any leaks? And we want to keep it low, making sure we don't have leaks. And then over time, when they get in the ICU, it's going to go back up.
It will.
To what the normal numbers are.
It will. And and I'm assuming you're a surgeon, and maybe you are, maybe you're not. And I'm not trying to be disrespectful. I'm more trying to be funny. Yeah, if you sew well, shouldn't be a problem. So hopefully you're not one of those surgeons that take forever to do the case. Okay, next question. But very good question though. That was it?
Yeah.
You said you
What
had
was the other
questions.
No, there was 2 questions. Yeah.
Well, I
first
didn't
one
see the
was-
second
First
one.
one was about the pressure being 120. The second
Also,
one
the
was,
map and the yes, that is true. Your mean arterial pressure in the aortic root is going to
quite
be
a bit,
higher
because,
than peripherally.
Well, that's part of. We have to take what we get, and what we have access to are radial arteries that are way down here, and they're tiny little things, and the surgeon can push on them, and they go way up.
And anesthesia can't put them in well.
Yeah, well,
And they put them in real short, and they don't bury them, so it gets kinked.
there's a lot of problems. And then if you have a femoral artery, I mean, that's still pretty far away. And I think they're more reliable, but most people don't. Most surgeons and most anesthesiologists do not want to put a femoral in because it's an extra hole that they're going to have to hold pressure on probably, or worry about bleeding.
In a dirty groin.
Yes.
Infection.
And those are the things. So we take what we get. We've got a radial artery. When you're doing these big procedures, it is really good, especially when you're doing an axillary cannulation, to have your left radial instead of your right radial.
Yes.
But you kind of want both because you want to make sure the blood flow is not predominantly going down the arm and causing compartment syndromes. Because there's so much blood flow going down there, the water of the blood gets the blood gets backed up and the water comes out, goes into the tissue. Then you end up with this massive swelling, and that's bad. But you also need to measure femorally because you want to make sure the blood flow is actually going around all the way, and especially after you've done these, big repairs, and you got clamps everywhere, and you've got sutures everywhere, but we're doing the best we can with what we got. That's the major point.
I agree with you 100%. Okay. Next week, thank you all for the participation and question. Next week, or not next week, 2 weeks, November 8th, PerfWeb 96. Thomas DeSalvio will be the host. The title of the program is?
ECMO, it's not just a 4-letter word.
Absolutely. And we're going to have some guest speakers, and I think it's going to be an incredibly...
You absolutely do not want to miss this one. Set the alerts to go off. We have something planned. This is so exciting, Joe.
I think so. It's going to be a lot of fun.
Yeah.
We have, yes, I don't want to be a spoiler. We have some real interesting things that you're going to see. You'll never see anyway. It's very difficult to see what you're going to see. It happens, but it's very rare, so you have an opportunity here.
I am very proud to be a part of this. First off, all the time. I love being here and putting on these presentations and just sharing my thoughts. I can't say my knowledge because it could be right, it could be wrong, but my thoughts on where I'm at right now, because everything changes over time. But this next PerfWeb, we have got something great.
Yeah, I think so too. And don't underestimate yourself. You're pretty smart. You're the smartest guy I know. Anyway, with that said, we'll see you November 8th. Be safe. Thank you all.
Cheers.
We're out.